So what we're going to do is we're going to do a live discussion on each topic. Let's say, I'll give an example. On September 1st, imagine that we're going to do anatomy, okay? So we are going to do anatomy from morning around 8:39 to evening 6:37 in 2 sessions. The morning will be the live discussion of all the questions of these high-heeled, hot competency areas of INI-CET going in depth. And then we'll stop it by evening, around 2 more hours left as a second session, where we'll take all the images alone in asked in the last 5 years in INI-CET and the entire subject together and discuss the images alone to give you a focus on image-based questions and the applications around these topics. So it will be 2 parts in the bootcamp. One is the hardcore competency review of the entire subject, connecting you to each and every topic, and then a second smaller session of discussing all the images of the particular subject. Understood? So that is what is done on the day 1, and then you'll get 2 days to study. Like after first day anatomy, 2 days to revise or 1 day to revise anatomy by yourself from your primary notes, so that you can make sure that you get the 130 base correct. Understood? If not, studying this high yield area alone will never get you INI-CET. You have to make your fundamentals and basics strong and revise everything up. It's very, very important. Understood? So you do that 1 day revision and then you write the anatomy exam on the second day evening in the Medico app. And the next day, let's say if it is dermatology, 1 day dermatology, same thing. Morning the competency review topic question discussion, evening the image-based question discussion. Next day, time for you to study by yourself, evening exam. Then it's 2 days medicine. 2 days we'll discuss all the systems like this. Morning we will discuss the competency review topics. After that, evening image discussions. 2 to 3 days holiday, and third day evening exam. So that you are having a revision track to come back to your original notes, understand these are the areas to study, focus and learn more or go deeper. Also review a quick review of all the images and topics in the subject and making sure you touch your base notes completely, so that you're going to improve from week on week. So how do we assess that? Every week there will be an INI-CET mock test happening in Medico app, which you can come in and take, so that you will understand your score is improving or not.
everyone. So we shall begin our discussion on important images for the INI-CET exams from dermatology. So the first image I have is a section of skin. So this is the environment. This is the outside of the body and this is the inside of the body. So from the outermost to inner layer, so we are looking at this, and above is the epidermis and beneath we have the dermis. So from the outermost to innermost layer, let us see the different layers of epidermis. I know this, almost everybody might know this. It might be a little boring, but it is important that you don't forget this because it repeatedly gets asked. Different layers of epidermis, what are the important structures? So revise yourself again. So this is stratum corneum. This is stratum lucidum. This is stratum granulosum. This is stratum spinosum. And this is the single layer of columnar cells. This is stratum basale. Now let us look at how this epidermis is invaginating into dermis. So this is known as a rete peg or rete ridges. Now this part of the dermis that is kind of protruding into the epidermis, this is known as a dermal papilla. So why are identifying these layers important? Because the questions are framed in such a manner that you need to know which layer you are talking about also, and the important structures and clinical implications of those things. So let us look at stratum corneum first. So in the stratum corneum, as we all know, it is like a dead layer of cells which are very flattened, which does not have nuclei. So it is the only layer in the epidermis which does not have a nuclei and hence are metabolically dead. But so what is the important structure there? So brick and mortar model is what we call for the structure of stratum corneum. So what is a brick and mortar model? So let us see, this is a brick, two bricks, and that is being held together by mortar. So what is this bricks made of? These bricks are made up of proteins. And what are these proteins? The most important being filaggrin. And what is this mortar made of? This mortar is made up of lipids. And what are the most important lipids that we should know about? Fatty acid, cholesterol, and ceramides. These are present in 1:1:1 proportion, hence forming the mortar. So this is how the stratum corneum is arranged. Okay, and the absence or the deficiency or the in very low birth weight infants, we see that the stratum corneum is very thin or underdeveloped, due to which there can be a lot of transepidermal water loss. This is a question that has been previously asked. Deficient in very low birth weight infants. Now let us look at stratum lucidum. It is a clear layer and it contains elidin granules. And how is it important? The clinical implication is that it is only present in the tough structures like palms and soles. So technically, except for the palms and soles, the skin has 4 layers, and while in the palms and soles, there is 5 layers, including stratum lucidum. Now let us look at stratum granulosum. So the name granulosum comes from the point that these layer of cells contain a lot of granules in the cytoplasm. So what are these granules? There are 2 important type of granules. One are the keratohyalin granules and the other one is Ortland bodies or lamellar bodies. So what are these keratohyalin granules? We were talking about the brick and mortar model. We were telling about the filaggrin that is present here. In addition to filaggrin, we have other proteins also, but the most important one is filaggrin. So these filaggrin are formed, the precursors of filaggrin are present in the keratohyalin granules. Profilaggrin. And now the Ortland bodies. What are the Ortland bodies or lamellar bodies? These bodies contains the lipids that were present in the mortar of the brick and mortar model we were telling in the stratum corneum. So these lipids are formed in the ortolan bodies or lamellar bodies, and as they mature, they go up and become this stratum corneum with brick and mortar. So how is it clinically important? The deficiency of filaggrin is implicated in ichthyosis vulgaris, while the ortolan bodies, multiple mutations, different type of mutations in the lipid transport, lipid formation, etc. are implicated in autosomal recessive type of congenital ichthyosis. And now coming to stratum spinosum. So in stratum spinosum, as we can see, this is what is forming the bulk of the epidermis, right? So in the stratum spinosum, while this is forming around 3 to 10 layers thick, this is connected to each other, not only just stratum spinosum. The name spinosum comes from the fact that these cells have spine-like projections, which are basically desmosomes. But we know that it is not just in the stratum spinosum. All the epidermal keratinocytes have desmosomes in it, but they are most prominent in the stratum spinosum. They become more prominent when the water is seeping in between the cells and making these desmosomal connections more prominent. And that process is known as spongiosis. Right. In this layer of the skin, in addition to keratinocytes, we have another important structure that is known as Langerhans cells. So what are Langerhans cells? These are antigen presenting cells. And why are they important? The aberrant proliferation of Langerhans cells are implicated in Langerhans histiocytosis. The immunohistochemistry of Langerhans cells are important because that helps us in detecting them. So what are they? CD1A, CD207, which is also known as Langerhans, and S100. On electron microscopy, these cells show Birbeck granules. Now let us look at the stratum basale, the lowermost layer of the epidermis, which is a single layer of columnar cells. And what do they contain in addition to keratinocytes? They also contain melanocytes and Merkel cells. Okay, this has been asked in different various and forms on different exams. So I propose that you keep this images PDF with you. Do rapid revision in between. Just go through the slides once just to get yourself acquainted to the images, just the images with very basic information about them. Okay, now let us look at the second image. So in the second page, we are basically discussing about different shapes and configuration of the lesions. Let us see. So this is a lesion which has a very well-defined, largely a well-defined border, right? And it is completely filled. As we can see, it is completely filled. So this type of a lesion is known as a discoid lesion, also known as nummular lesion. And the most common example for such a lesion would be nummular eczema or discoid eczema, right? Now the next one, as we can see, has a well-defined elevated border which is quite distinct from the center of the plaque. So this is known as, such a morphology is known as an annular lesion. And why is it important? It has been asked in previous INI-CETs also to describe which are the conditions which presents with annular lesions. And some of the examples that you should remember are tinea, the common one, the favorite one, everybody knows. In this image, what we are seeing is also known as porokeratosis. This is also an annular lesion. For the inverse, this porokeratosis has a very distinct thin layer of border that is forming, and it is, if you put a dermoscope, if you magnify it many times, you can see that it is actually a double ridged one. And on histopathology, you will see coronoid lamella. Not very important, but just to know that porokeratosis is also a type of annular lesions. Now coming to the third side, granuloma annulare. These are easy because the name itself says that it is annular. Another type of skin lesion which has annular lesions are subacute cutaneous lupus erythematosus. Cutaneous lupus erythematosus, also known as SCLE. Okay. Now coming to a different morphology. We can see that there are arcuate lesions here. Some of them are even polycyclic. Some of them are forming a complete circle. So these are annular. So this is forming an annular, arcuate, polycyclic. So these kind of lesions are known as figurate erythemas. They start, then they expand, and then they coalesce and form these different beautiful structures. So the classically figurate erythemas has been, the classical 4 types of figurate erythemas are erythema annular centrifugum, erythema gyratum repens, erythema marginatum, also erythema migrans or erythema chronicum migrans. So erythema migrans is seen in Lyme's disease. Erythema marginatum is seen in rheumatic fever. Erythema gyratum repens is a favorite paraneoplastic syndrome of skin, which is seen in bronchial carcinoma. This has a characteristic woody grain appearance. And then we have erythema annular centrifugum, which sometimes form as a hypersensitivity to any type of insult, which can be infectious or non-infectious, and sometimes is a diagnosis of exclusion. So this classically has a trailing scale. That is, the scale is in the inner part of the annular layer. Now let us look at some kind of configuration, lesions which appear in a linear configuration. These are favorites of INI-CET examiners. As we can see, these are lesions of a skin disorder which are appearing, if you draw a line across, which is appearing in a line. So this is the lymphatic drainage, and such a lesion is known as lymphocutaneous lesions. And the classic example for such a lesion is sporotrichosis. And sporotrichosis is not the only skin disease that presents in a lymphocutaneous configuration. The other examples are atypical mycobacterial infections, leishmaniasis, and nocardiosis. At least remember these 3. Okay. Now coming to the histopathology of sporotrichosis, what we are seeing here is the organisms that are here, which is surrounded by dense eosinophilic substance that is radiating to the periphery. So this gives a star burst appearance, also known as asteroid bodies, also known as Splendor-Hupli phenomenon. Usually these asteroid bodies are surrounded, because these are foreign objects which are surrounded by these material. There are different hypotheses about this. People say that these are the antigen antibody complexes that are formed and deposited around the organism. Usually these asteroid bodies are surrounded by acute inflammatory infiltrates like eosinophils and neutrophils. Now let us come to the star, which is sporotrichosis. Almost every other year, there is a question that is being asked about sporotrichosis, either about its distribution, pattern, treatment, something like that. So it is caused by Sporothrix shingii, which is a dimorphic fungi. And the clue for you in the question, the Q will be something like a patient who is from a sub-Himalayan terrain like Himachal Pradesh, Uttarakhand, somebody with a history of trauma, or somebody who does a lot of outdoor activities like a farmer or a gardener who had some trauma with thorn or a plant, something like that, and with a characteristic histopath showing Splendor-Hupli phenomenon. Now, Splendor-Hupli phenomenon is not only seen with sporotrichosis, it has been described in various infections, including viral, bacterial, parasite infections, and even in non-infectious disorders. But at least the 2 or 3 that you should remember is, again, 1, sporotrichosis. You should also remember botryomycosis and other deep fungal infections like lobomycosis. Okay, and the drug of choice in sporotrichosis is itraconazole. But if it is forming a disseminated form, which is quite rare, in that case amphotericin B is the drug of choice. We have another type of cutaneous sporotrichosis, which is known as a fixed sporotrichosis, which does not spread along the lymphatics. That is a rare variant. Now coming to this lesion. So as we can see, there are cutaneous lesions which are again arranged in a line. And this specific phenomenon is known as Qbnerization or isomorphic response. So what is Qbnerization? So Qbnerization is the appearance of new lesions on a previously unaffected skin secondary to trauma. But the catch here is that these lesions that form secondary to the trauma, they are quite similar. They are similar to the primary disease. So if a patient of psoriasis is developing Qbnerization, the lesions which are developing on the site of trauma will look exactly like psoriatic plaques. So the classic examples are lichen planus, psoriasis, and vitiligo. Now, this is true Qbnerization. What is a pseudo Qbnerization? So what happens is that in infective disorders like wart or molluscum contagiosum, because of the trauma, likely like scratching or something, which implants these viruses along the line of trauma, along the line of scratching, which gives an appearance that these are also similar to the previous primary lesions, but these are due to auto-inoculation of the virus along the site of trauma. Right. So the classical examples are molluscum contagiosum and verruca vulgaris. It is an important question, has been asked multiple times. Now let us look at this question. So there is a 60-year-old, again we are still sticking to the linear configuration. So let us see, there is a 60-year-old patient presenting with lesions given in the image below. He describes having a sensation of spiders crawling in the area of skin lesion when he woke up. What is the likely diagnosis? So let us see. So this is a lesion that is present, almost linear but a broad linear. It is like a block, and the cutaneous lesions are grouped vesicles. So it is an easy answer for most of you. It is herpes zoster infection, or also known as shingles. So what is the catch here? They have mentioned a sensation of spiders crawling in the area. So that might give you a sense, could it be a spider crawling and causing a secondary irritant or a contact dermatitis that is causing the bulla and vesicles? But what we should remember is that in herpes zoster infection, there can be a prodrome. Prodrome means before the actual vesicles develop, patient actually feels like there is something that is about to happen. Some people feel it as pain, some people feel it as itching, some people feel it as crawling sensation. So some kind of a paresthesia, and they can last longer. They can last after the skin lesions have resolved also, which is known as post-herpetic neuralgia. So this is a herpes zoster infection. Has been asked multiple times. It is a repeated question, and never to miss this question. Now, this characteristic distribution that we are seeing as a block, this is known as a linear block. So that is known as dermatomal distribution, and dermatomal distribution is based on the nerve supply of the layer. So this segment is supplied by certain spinal nerves, and that is the reason for the dermatomal distribution of these skin lesions. And what is the classical example? Herpes zoster. We have other examples like segmental neurofibromatosis. Now let us look at a different kind of linear configuration or a segmental involvement. So here we have a area, a block of area where the patient has leukotrichia, that is the white hair, and localized area of depigmented macules. This has been asked at least twice before to differentiate between the options that are given here, that is vitiligo, piebaldism, and nevus depigmentosus. So let us dive in. So how are these three different? So in segmental vitiligo and piebaldism, what you are seeing is a completely depigmented lesion. Early lesions of vitiligo can be hypopigmented, but the classic lesions are depigmented. While in nevus depigmentosis, what you see is hypopigmentation. There is no complete loss. It is just hypopigmentation. So if you are seeing a plaque which looks completely white, then it is not nevus depigmentosis. Now let us look, when does this present? Piebaldism is present since birth. while nevus pigmentosus is also around the same time, birth or early childhood. But in segmental vitiligo, even though it is more common in younger adults, it kind of progresses over time, then it becomes stabilized, and then it becomes non-progressive. That is, it progresses whatever segment it is supposed to grow in. So for this example, this is the segment that the segmental vitiligo is in, but it won't grow beyond this. So at a point, the lesions get restricted to that segment and then become non-progressive. While pybaldism, as we can see, will not progress further. It is sticks to wherever it is there, and the nevus depigmentosus is also the same. And in pybaldism, we have to remember it is the mutation in c-KIT gene, and it is an autosomal dominant disorder. And how does it present as? As we can see, there is a white forelock. We can see leukotrichia here, white hair. Along with that, there is almost a triangular appearance that is in the middle of the forehead. This can extend down till the nose. So, in addition to this, what are the other features of pybaldism? So this white forelock with this triangular patch of depigmented macule, that is present in almost all patients, about 80 to 90%. But what is characteristic is this islands of normopigmented skin or normopigmented skin or hyperpigmented skin that is present as islands in between these depigmented macules. Other classical sites for pybaldism are, if this is the human body, and this is around the joints. This is so this area, that is middle of the extremities. So we have middle of the extremities around the joints like this. And we can have involvement of the trunk also. As I had mentioned before, it presents as depigmented macules with areas of hyperpigmentation. Now coming to nevus depigmentosus, it usually has a well-defined border, but this border, even though it's well-defined, is very irregular, feathery. Okay. Now repigmentation. Repigmentation in vitiligo is possible if it is in the progressive stage, you medicate, it is possible for it to repigment. While for pybaldism, it is impossible to repigment unless you are doing some vitiligo surgeries for with melanocyte transfer, etc. And in nevus depigmentosus, it is not possible to repigment. And leukotrichia can be present in segmental vitiligo and pybaldism, but not in nevus depigmentosus. So let us look at this question again. So we have ruled out that it is not nevus depigmentosus because it is quite white, and not pybaldism because it is not in the characteristic area that we were. The distribution is little off. So the best answer would be vitiligo, and in that we have a focal vitiligo and segmental vitiligo. So how do we differentiate focal versus segmental? So focal vitiligo is defined as one of few macules that are present in a specific in an area of the skin that is not segmentally distributed. So the criteria for to call as a focal vitiligo is that it is a limited lesion, but it is not in a segmental pattern. So if you can see a segment, if you can delineate a segment there, then it is a segmental vitiligo. So what is the basis for distribution of segmental vitiligo? There are different theories. Some say it is dermatomal, some say it is angiosomal, some say it is blascolinear. So it could be either one of them, but it just means that a segment of the body is involved. Okay. Now coming to the similar lines, what is the following is untrue regarding pybaldism? It is an autosomal dominant, we had mentioned it before. Amelanotic skin associated with white forelock, correct. There is islands of normal or hypermelanotic skin, we had mentioned earlier, yes. It usually improves with age, no. There is no improvement with age, it is fixed. The area is fixed. Now let us look at the another next image. Now we are going to look at the lines, important lines in dermatology. So what are we seeing? Kindly excuse me, it is. So what are we seeing? So I want you to observe there are two type of lines that kind of is confusing but has been asked multiple times in exam, and identification is very necessary. So for these kind of lines that I am going to show you, on the scalp, it is quite circular, while on the back, it is fountain-like. It is like a fountain. While on the lateral trunk, it is forming S shape. It's a little odd S, but it is an S, right? So it is forming S shaped. So these 3 points will tell you that this is Blaschko-linear. Now I'm showing you some examples of Blaschko-linear lesions. These are hypomelanotic patches that are present, again, fountain-like on the back, if you can see. The S shape here on the lateral trunk, right? So I don't have a scalp lesion. So these are distributed in a Blaschko linear pattern. If you are even not able to identify what the exact disease is, and if they have asked about the patterns, these are things that you can look at and say what is the pattern of distribution. So this is a verrucous epidermal nevus known as VEN. This is hypomelanosis of Ito. This is again a VEN. That is, how do you understand a VEN? VEN has a hyperkeratotic. Hyperkeratotic means thick, elevated, black colored plaque that is distributed along the lines of Blaschko. And this is hypomelanosis of Ito. Now let us look at these kind of lines. This is a different type of line. On first look, it might look similar, but these are different. Let us look at the scalp. It is not circular. It is more linear, and we can see in the back of the trunk it is not forming the fountain that we were thinking, but it is rather forming a Christmas tree pattern. We have discussed this earlier also. These are pityriasis rosea that is arranged in this Christmas tree pattern, and on the lateral trunk they are forming very straight lines. So why are these lines important? These lines are also known as Langer's lines or skin tension lines. So it basically tells what is the direction of the collagen fibers underneath and what is the direction of the muscle. They are usually perpendicular. Why are they important? Because there is in addition to pityriasis rosea, it has a lot of surgical importance. Why? If this is back and this is the Christmas tree that is being formed, orientation of the incision lines along that skin tension lines will result in an easier closure of the wound as well as better scar in the post-surgical period. So how to differentiate? I have already mentioned you these points. These are skin tension lines, Langer's line, while Blaschko linear lines are based on how the embryonic epidermal cells migrated through in their embryonic period. Now this is how you differentiate between these both lines, and I have shown you classical examples and how these things are important clinically. Now let us look at these lesions. So this is a site. Usually in the examination they will give you this background information. This is a site where the patient got a intravenous needle injected, and at this site the patient has developed such a lesion. This is known as pathargy. And what is pathargy? Pathargy is at the site of intravenous or hypodermic needle insertion. There is formation of erythema induration with papule formation and sometimes even a pustule. This is characteristically seen in Behçet's disease. Behçet's disease usually presents as bipolar aphthosis. Bipolar aphthosis means there is aphthous ulcer that is present in two sides, mucosa and oral mucosa and genital mucosa. Along with that, they have eye symptoms like uveitis. Now, it is also not only restricted to Behçet's disease, but it is also seen in pyoderma gangrenosum and Sweet syndrome. These are also again neutrophilic dermatosis. And how are they different from Kebnerization? Some people, because here the lesion that is being formed may not be similar to what is the primary morphology of the lesion. So in pyoderma gangrenosum, as we can see, this is a photo of pyoderma gangrenosum known as PG. And in pyoderma gangrenosum, what we see, a primary lesion is a pustule which eventually becomes an ulcer with a very violaceous border. This is very characteristic, and these violaceous borders, they have this overhanging margins, etc. So pyoderma gangrenosum is an example of a neutrophilic dermatosis which can form, which can give pathogen. Again, here we can see the violaceous border. Pyoderma gangrenosum has a lot of associations. This has not been previously asked, but if such an image comes, the common association, around 50 to 70% of pyoderma gangrenosum is associated with some systemic illness. This includes inflammatory bowel disease, arthritis, usually seronegative arthritis, also hematological disorders. This includes hematological malignancies, non-malignant hematopoietic disorders, etc. Now let us look at this. So this is a genitalia. If you can see, this is female genitalia. What we can see here is that there is a hypopigmented lesion, right? Or almost depigmented. The color is gone. It is not of the normal skin color. And what we can also see here is that it is quite shiny. You can see this area of the skin, and then you see this area of the skin. This is quite shiny. So when skin is showing a lot of shininess, that means the skin is atrophied. So what we are seeing here is depigmentation or hypopigmentation. What we are also seeing here is some atrophy. And it is, where is it formed? It is surrounding the vaginal introitus. You have your urethra here, then this is your clitoris. So it is surrounding the female external genitalia. And if you had a close enough look, this might also be surrounding the perianal region. It is not necessary that both are there, but it is usually it is a common association. So what we are seeing here is a figure of 8. It is encircling the female external genitalia as well as the perianal skin. So this, it is not restricted to females. The males can also have lichen sclerosis. So the disorder which is lichen sclerosis. Because the skin become atrophied, it also eventually scars. That is where the sclerosis comes from. Because of a lot of sclerosis, the collagen fibers changing its morphology to become more thick, the sclerosis causes blockage of different pathways that there are here. It can restrict the urethra, it can restrict the vaginal opening, causing dyspareunia, pain while having sex. Then it can also form some kind of difficulty in defecation also. But that is of course in later on stages. So for lichen sclerosis, what is the treatment? You can give topical steroids, topical calcineurin inhibitors, etc. But in the question what they have asked is to identify what this skin lesion is, and it is lichen sclerosis. It is not a sexually transmitted disease. It is a non-infectious, non-venereal genital disorder that is usually seen in both men and female, and it is associated sometimes, not sometimes, most of the times, with intense pruritus and burning. This may be your keys in your examination in the question. Now let us look at some of the STD pictures that we had seen earlier, but I don't want you guys to forget it, so I'm going to show it again. So these are grouped vesicles, which is leaving behind erosions in a polycyclic manner. And on zinc, they are showing multinucleate giant cells. These are acantholytic cells. And what is so characteristic about this multinucleate giant cells? 3 M's. They are multinucleate, that is fusion of multiple nucleus together. They show margination. What does margination mean? The nucleus becoming marginal near to its nuclear membrane. Then it also shows molding. Molding is because of different nucleus are coming together, so they adjust their shape according to the nearby nucleus. So this is characteristically seen in herpes simplex. Now let us look at syphilis. This is DGM showing Treponema pallidum, and this is the single indurated. See the base of this lesion, it is clean, and once you press it, you will have homogeneous exudate, which is highly infectious. So this is primary syphilis, also known as hard chancre. Now let us look at this. So this basically shows a small ulcer here and then a swelling in the inguinal region, and this is inguinal bubo, which is preceded by a transient which lasts about less than a week. Sometimes it goes unnoticed, and the patient presents with painful, usually unilateral more than bilateral, suppurative multilocular swelling in the inguinal region, and this is lymphogranuloma venereum. Now this is a little bit dirty looking ulcer. Here we have at least 2 ulcers. These ulcers are very painful. That will be given in your history, and as we had mentioned earlier, if it is a painful ulcer and it is not polycyclic with preceding vesicles, then it is chancroid. And let us look at the base of this ulcer. It is dirty, there is a lot of necrotic slough. And now, what does they look on a gram stain? So on a gram stain, you can see there is a school of fish appearance. It is arranged in this pattern. Now let us look at this. It is a granulating, beefy granulation tissue that is present in the genital region, and this is donovanosis caused by Klebsiella granulomatis, and these are safety pin appearance of how they appear inside mononuclear cells. This we had discussed earlier, but I am showing it to you again so that you don't forget it. These are secondary syphilitic lesions, coppery red, asymptomatic, coppery red. They are asymptomatic, they are symmetrical, and usually they are generalized. These are special lesions of syphilis on palms and soles known as beard collarate. Now these are condyloma lata. Look at these moist, very wet looking lesions. These are highly contagious. And these are the moth-eaten alopecia. In the right context, this is moth-eaten alopecia. You cannot look at this and you yourself can't call it moth-eaten alopecia, even though it looks like it, but you will have some clinical context which will suggest you that this is moth-eaten alopecia of syphilis. Now this is secondary syphilis. Now let us look at tertiary syphilis. How does it look on skin? So this is a gumma. You can see a raised ulcer with a necrotic base. And most very characteristic of syphilis is how it causes septal perforation, palatal perforation. And this has been asked in one of the previous year INI-CET exams. At what stage of syphilis do you see septal perforation? And that is in tertiary syphilis. And you can also see it in another situation, that is congenital syphilis. In congenital syphilis, you have early congenital syphilis, that is less than 2 years, and late congenital syphilis, that is more than 2 years. If the child is born infected with syphilis in utero, So there are a lot of changes that can happen because of the infection with Treponema pallidum during organogenesis and the later stages of development. That is the cause for early syphilis, and that usually presents like secondary syphilis. The clinical symptoms are more or less like secondary syphilis, while the late syphilis happen once the child is more than 2 years old, and that is usually like tertiary syphilis. That is because of the hypersensitivity to the remaining treponemal antigens in a untreated patient with the congenital syphilis. So I'm not in detail talking about these things, but in the early congenital syphilis, what you will see is a child who looks marasmic, who looks very ill, very thin, and they have a pot belly with hepatosplenomegaly and cutaneous, like with the cooperated lesions that we were seeing. They can have a generalized rash like that. They can have palm and sole thickening like we saw before. They have thick nails and a characteristic lesion over their palms and soles known as pemphigus syphiliticum. Right, and these are the characteristic cutaneous lesions. Now, as the child grows up, you will see that there is denting of the incisors, which is known as Hutchinson teeth, and these are molars which multiple ill-formed cups, which is known as mulberry molars. Now let us come to the nail disorders. So what are we seeing here? So when a photo of nail is shown, you start looking at it systematically. So what are you seeing on the nail plate? So we are seeing a lot of pits, right? There is a lot of pits, and these are not like fine pits. These are deep pits. These are coarse pits. Another thing you are seeing is this yellowish discoloration. If you look beneath these nails, you can see subungual hyperkeratosis. It just means that subungual, beneath the ungum, ungum is nail, there is hyperkeratosis, there is thickened skin. So there is material that is beneath the nail. Subungual hyperkeratosis, there is pitting. There is also separation of the nail from the nail plate, which is not very obvious, but looks like that. So that is known as onycholysis. And here we can also see, even here it is there, it is not very prominent. Here also it is there. This is known as a salmon patch. This all in all is causing nail psoriasis, pointing to nail psoriasis. Important question has been asked before. Important to understand what are the features. Patients who have nail psoriasis are more likely to have psoriatic arthritis too. Now let us look at these nails. So these nails, you can see that there is quite thinning of nail. If you can see here also, these nails are quite thin. They have a lot of longitudinal ridging. Longitudinal ridging just means that there are ridges in the nail that is along the axis of the nail. And we can also see that there is a lot of longitudinal clefting also. There is separation of the nail plate. Then there is onycholysis. There is frankly loss of nail. And you can see the proximal nail fold that is becoming fused with the nail plate, and that is known as pterygium formation. And this is almost complete dystrophy of nail, almost going to lose the complete nail. Loss of complete nail is known as anonychia. If you see such a situation, this is a dystrophic process. The nail is completely getting destroyed, and this is classically seen in lichen planus. In addition, you can have a pup-10 deformity also. Now let us look at these nails. So on first look, what we are seeing is rough nails. These look like sandpaper nails. So these are commonly idiopathic. Idiopathic tracheonychia is quite common. Sometimes it can be associated with alopecia areata. But when it is with alopecia areata, the tracheonychia, the sandpaper nails are not so coarse and deep. It is usually because of the fine geographic pitting of nails. Now let us look at this. So we can see that there is lines, ridges. It's not just lines, there is indentation. The nail, there is depth to the lines that we are seeing. So this is known as Bue's lines. This is known as Bue's lines. So what is Bue's lines? This is the nail, and here is where you have the matrix of the nail. So there are something that is happening in the body. It is usually a systemic condition, like there is some malnutrition, there is some severe infection that the body needs to fight, and the nutrients to the matrix is decreased or lost. That is why transiently there is no process of nail being made. So that is why there is transient loss of nails. So the matrix is intermittently being disturbed. The growth of the matrix is intermittently disturbed, which is causing the Bue's lines. And that is usually associated with any systemic conditions like malnutrition. The patient is having to fight any serious systemic infections like typhoid, malaria, patient had any serious dengue, chikungunya, anything. And sometimes it can be because of the local trauma also. Some trauma that has happened, some chronic paronychia that has happened because of that too. It can be this partial, like forming part of the nail, or sometimes it can be complete. It need not essentially be that it is just part of the nail. It can sometimes be complete ridging of the nails. Now let us look at this. This is known as onychomatosis. So what is onychomatosis? So the separation of the nail proximally. So when it is breaking from here, that is known as onycholysis. But when it is breaking off from here, it is known as onychomatosis. So the nail is separating from the proximal part, and that is usually seen in HFMD, hand, foot, mouth disease. In HFMD, as we had shown earlier, it also has a vesicular eruption predominantly on the hands and foot with some oral exanthem. Oh, sorry, oral enanthem. Now this is pus filled around the lateral nail fold and extending into the proximal nail fold. This is paronychia, and not just paronychia, this is acute paronychia, and it is usually caused by staph infections. Okay. Now let us come to systemic dermatology. So what are we seeing here? There is bluish discoloration. Bluish discoloration of the fingers. It is the acral sites, means the finger, the distal most part of the body. This includes the fingertips, the toe tips, sometimes the toes and nose. So here what we are saying is bluish discoloration. And in addition, you can see the pits here. If you zoom in, you might be able to see the pits here, digital pitting scars. You can even see an ulcer with loss of some part of the finger resorption. So these features are suggestive of a Raynaud's phenomenon, and just not any Raynaud's phenomenon, likely associated with systemic sclerosis in view of the other features like pitted scars, digital resorption, digital ulcers, etc. So at what stage of Raynaud's phenomenon is this in? Initially what happens is that because of the vasoconstriction, so the patients with systemic sclerosis or Raynaud's syndrome have abnormal vascular response. In response to cold stimuli, there is sudden vasoconstriction which causes whitening. Followed by that, there is bluish discoloration because of the cyanosis, and then it becomes red because of reflex vasodilation. Now, in addition to this, which most of you might know, there can be this peculiar pigmentation which is known as salt and pepper pigmentation. So as you can see, it is dot, 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 white dots in the background of a skin. It is more apparent in our skin tone. So this is known as salt and pepper pigmentation, and this is seen in systemic sclerosis. In addition to that, you might also know that the skin might be thickened, there may be sclerosed, and you will have on the faces, we have a lot of changes that you can see. The Ingram sign enabled to pull down the lower eyelid, then you have beaking of nose, then you have pursing of lips, then you have mat-like telangiectasia that is present over the bilateral malar area. So these are all other features that will help you, but characteristically when you look at this hands and body, this is what you can see. And how do you assess severity of the systemic sclerosis? That is based on modified Rodnan skin score. It is also known as MRSS. Okay, now coming to another systemic disorder with cutaneous manifestations. This is very apparent that this patient has a violaceous, a purplish plaque that is present here, right? even here. But it is something in our skin tone, it looks like some edema, some redness. So this is known as heliotrope rash. Now let us look at this. So there is prominence of these violaceous papules, even though this area is also involved, it is prominent here. So this is known as Gottran's papules. These lesions are present over the elbow also. These are known as Gottran's sign. These all are characteristically seen in dermatomyositis. Other features include a V sign, shawl sign, direction of the shawl, sometimes a V sign involving the photo-exposed part of the chest, includes a V sign. So these are the images that you need to keep in your mind. Now this is showing a proximal nail fold capillaroscopy. What is capillaroscopy? Basically, we are zooming in and seeing how the nail fold capillaries are looking like. These are important in connective tissue disorders like systemic sclerosis and dermatomyositis, to some extent in SLE, but very characteristically described in systemic sclerosis and dermatomyositis. What are we seeing? We are seeing dilated capillary loops. These are dilated. These are abnormally large. And there is some dropout. Normally, these are like this, uniformly arranged. But in systemic sclerosis and connective tissue disorders, they become enlarged, they become giants. Then you drop some, you drop few capillaries. These are known as capillary dropouts. Then you see some hemorrhage, as we are seeing here. So these are small hemorrhages. These are all suggestive of some connective tissue disorder with some vascular abnormalities like dermatomyositis or systemic sclerosis. Now let us look at another connective tissue disorder, the favorite of examiners. This is what we are saying is a malar rash or a butterfly rash. It is a butterfly rash. This patient also have not only a malar rash, but she has involvement of all sun-exposed parts, including her chest. Right. So that is characteristically described in which form of LE? Acute cutaneous LE. Now chronic LE. Chronic type of lupus erythematosus, cutaneous lupus erythematosus, can present with such a plaque which is known as discoid lupus erythematosus. How do you identify this? The periphery has a hyperpigmented margin. This is quite hyperpigmented, and in the central you have a depigmented plaque. And on close inspection, if you put a dermoscope, if you magnify it, you can actually see follicular plaques within them. So one of the characteristic sites is face is the most common site that is involved, especially the most photo-exposed parts. And sometimes you can see it over the scalp also, which causes scarring alopecia. Hair will not grow again there. Okay. Now, as we were talking about photosensitive disorders, which is in a photo-distributed manner, I'll talk about another photo-distributed lesion that is not connective tissue related. This is known as pellagra. This is the Castle's necklace. This is the photo-exposed parts that are involved, right? Photo-exposed part that are involved and which has an eczematous lesion. These are quite eczematous. It looks like there has been dermatitis, but in a photo-distributed patients. And the clue here, and this is caused by niacin deficiency, and this will have dermatitis, dementia, diarrhea, and as the fourth D, people say death too. But at least these are the symptoms that you should be keeping in mind. Right. And in the history, if there is some clinical context to this picture, they will say some patient who is malnourished, patient who is homeless, living in the streets, in some of that context where possibility is that the patient is nutrient deficient, because people who are taking a balanced diet is usually not niacin deficient. Now let us look at this genodermatosis, which has a lot of cutaneous lesions. These small papules, which can be small papules like this. It can be nodules like this. Sometimes it can be pedungulated like this, sometimes sessile like this. So these are known as neurofibromas. Along with that, you see a diffuse swelling on the face. These are very large. These are known as plexiform neurofibromas. Then you see this freckling that is happening predominantly in flexural sites like axilla, groin, etc. Then you have these macules, well-defined macules, which are quite a lot in number, and these are known as cafeole macules. This is classically seen in this constellation of these presentation is seen in neurofibromatosis 1. Okay. Now what we are seeing here is this distribution. Where are these papules that are more aggregated along this line? Right. So these are known as adenoma sebaceum. These small growth that is coming from the side of the nails, these are known as ungual fibromas or Kienan's tumor. These white macules are known as ash leaf macules. And this almost skin colored, barely perceptible change in texture, these are known as shagreen patch. And for exam, what you are most likely to see is either this or either this, and this is the cutaneous features of tuberous sclerosis. Now we're coming to the ichthyotic group of disorders. So in ichthyotic group of disorders, what sometimes I find it difficult just from the picture to make out a diagnosis, but here what we are seeing is this fish-like scales that are present, which are quite fine, and this is seen in ichthyosis vulgaris. And in X-linked recessive ichthyosis, one of the differentials, what you will see is more larger plates, which are more black, which are more adherent. These are semi-adherent or flaky scales. These are very adherent black scales. Okay. And how to differentiate? I had mentioned earlier, X-linked is more only seen in boys, so it can be seen in boys and girls. The involvement in X-linked recessive ichthyosis includes preauricular, neck and axilla and encroaching the other flexures, while in ichthyosis vulgaris, you have total sparing of the flexures. Now, ichthyosis vulgaris may completely resolve in summer, it just has winter exacerbations, but X-linked recessive ichthyosis never completely resolves, even though it can have some seasonal variations. Okay. Now look at these scales. So what we are seeing is more larger scales. These are becoming plate-like. I do understand that some of these names can be a little bit tricky, but what I want you to look at in addition to the scaling is how this lower eyelid is being pulled down, known as ectropion. Look at these being pulled down, it is known as eclabion. Ectropion is very prominent here. And it is quite generalized, right? It is quite generalized, and this is known as lamellar ichthyosis. Now let us look at the coming to the syndromic ichthyosis. Now we have just another one in the autosomal recessive congenital ichthyosis, which is harlequin ichthyosis. And what we see here is large armor-like plates. These are very quite large plates. Such large scales you can only see in harlequin ichthyosis. Now these ichthyosis, group of ichthyosis that I had mentioned before, ichthyosis vulgaris is autosomal semi-dominant due to filaggrin mutation. X-linked recessive is X-linked in inheritance, and it is because of steroid sulfatase deficiency. And in lamellar ichthyosis and its brother, the photo that I have not kept here is just diffuse erythroderma. So it is known as congenital ichthyosiform erythroderma. If it is too much for you, please remember lamellar ichthyosis because that can come as a spotter. And these both are brothers because this people consider it as a spectrum on one end and the other end. And these are also again mutations in the lipid metabolism, the cross-linking, transglutaminase, etc. That if it is too much, you just understand that this comes under autosomal recessive congenital ichthyosis, including harlequin ichthyosis. These three are the most important ones that you should remember. These are all non-syndromic ichthyosis. That means the disease is restricted to the skin. Now, what are syndromic ichthyosis? Syndromic ichthyosis are not just restricted to skin, but it has ichthyosis plus other systemic features. Now, we have two disorders of syndromic ichthyosis where there is ichthyosis, along with that there is hair abnormalities. Are you seeing this unruly, very ill-kept hair which is not growing in size? So these are hair shaft disorders. That is why they are not growing in size, but there is hair, it is not growing in size, it is unruly, and we are seeing tiger tail appearance. This is not on normal microscope, it is on polarized microscope. See these dark bands alternating with white bands, and this is seen in trichothiodystrophy. Okay. Now this is another ichthyosis, syndromic ichthyosis, which is associated with, again, hair changes. So what we are seeing is, if you look closely and if you can imagine, these are nodes that are present, and if you can imagine, this looks like bamboos with different nodes at different points. So this is known as trichorexis invaginata, and that is classically seen in Netherton syndrome. And the classic scaling that you will see in Netherton syndrome is ichthyosis linearis circumflexa. Double-edged scales. These are two-edge scales. Okay. What else will tell you that it is Netherton syndrome from the history point of view? They will talk about a child who is born in sepsis, who is sick, who developed hyponatremia, and eventually the patients, in addition to this ichthyosis, develops itching. They have features of atopy, they have asthma, rhinitis, they have atopic dermatitis, quite itchy. Ichthyosis is not always itchy, so they will have very itchy skin lesions, and that will suggest, in addition to these skin lesions and hair changes, will suggest you that it could be Netherton's syndrome. Now let us look at these lesions. So these are very flat. As you can see, these are very flat lesions. So this distribution, as we can see, it is in a segmental distribution, right? So this is a capillary malformation, also known as port wine stain. How is it important? It is associated with a few syndromes, and among them, the most important one is Stouge-Weber syndrome. It is associated with not only the malformations, capillary malformations in the skin, it is also associated with malformations in the ipsilateral, the same side, the leptomeninges can also be having malformations along with choroid malformations. So patient will give history of seizures, intractable seizures in the infancy. Along with that, the patient might have intellectual disabilities, etc. Along with that, few of the patients can have glaucoma with this characteristic stain on their face. It is important to notice that if the patient does not have involvement of the V1 or the upper eyelid, it is highly unlikely that the patient has Stouge-Weber syndrome. They might just have a capillary malformation. Now, these are more elevated lesions. It is not flat, these are elevated. These are known as capillary hemangiomas. How is it different from capillary malformations? Malformations are abnormal networks, abnormal growth that is since birth. It is developed during the organogenesis and it will not grow further, it will grow proportionate to the patient's body. While capillary hemangiomas are abnormal growths, they are vascular tumors in a sense that develops usually after the birth. It has a rapidly expansive phase where it grows very rapidly up to maybe about 6 to 9 months. After that, it slows down and then it begins to regress on its own even without treatment. So what is important in a capillary hemangioma? Our phase, especially if it is large, you should be thinking about phases syndrome. What does phases syndrome stand for? Posterior fossa anomalies, hemangiomas, arterial anomalies, cardiac anomalies, eye anomalies, and sternal clefts and supraumbilical raphe. If it is too much, at least remember the phases which can present with brain, it can present with heart and its vessels, eyes, and again a hemangioma. Okay, and what is the treatment for hemangiomas? If the patient has a hemangioma which is larger, which is over important parts of the body, which has cosmetic importance, sometimes if it can threaten your vital organs, if it is just near the eyelid, it can cause amblyopia. If it is near the jaw, there is risk of having internal laryngeal hemangiomas, etc. These are all indications toward systemic therapy for hemangiomas, and the drug of choice is propranolol, which is given orally. Okay. Now coming to some of the infectious disorders, what we are seeing here is a tumor factor. It is a tumor-like swelling, and over the swelling we can find different places where there are sinuses. There are opening to this swelling, and in these openings, if you look closer, you will find there are black dots. So these triad of swelling, discharging sinuses, and black grain, it may not be essentially black, discharging grains, this triad is seen in mycetoma. So you can have two types of mycetoma: actinomycetoma, which is caused by bacteria, and eumycetoma, which is caused by fungal elements, right? Now let us look at this picture. So we were talking about atopic dermatitis earlier. So this is an infant with atopic dermatitis who has involvement of the face, cheek involvement, scalp involvement, perioral dermatitis, periocular dermatitis. So this is a baby with atopic dermatitis, and this is something which came for the exams where there is changes which are present in the flexures of the skin. This is what is known as lichenification. What does it show? There are increased, accentuated skin markings that are present if you can see closely, and there is hyperpigmentation, there is change in color, and there is some thickness in this area. So this is known as lichenification. And this is Denys-Morgan folds. This is seen below, which is crossing the midline. This is a Denys-Morgan fold. Again, it tells us that the patient has atopy. In addition to that, you can also see hyperlinear palms, keratosis pilaris, which is basically follicular papules, small papules that are present usually over the upper arms, back, etc. Okay, now let us look at these kind of lesions, which this is the active stage. This is one it's had resolved. So you can see these are oval in shape, some circular. These lesions in active stages have, in addition to this black color, there is some redness, there is some swelling, sometimes there can be even a bulla, and when they resolve, they leave behind intense hyperpigmentation. And these are known as fixed drug eruption, and a diagnosis of FD is made when the same site is involved on repeated intake of the same drug that has caused the reaction on the first place. So what are the drugs that can cause fixed drug eruptions? As an example, most commonly you should remember cotrimoxazole sulfa drugs, metronidazole, this has been asked in 2 exams, and maybe NSAIDs. These 3 at least you should remember. Okay. Now coming to these lesions. So what are we seeing here? There is a central red dot, then there is a pale periphery, then there is a erythematous outer periphery. So this is known as a target sign. These are target lesions. Now, what are we seeing here? There is no three zones here. There is just dusky erythema and there is this paler. This is known as a targetoid. This is not exactly target, but it is target-like or targetoid. So, what are these lesions seen in? The target, classic target lesions are seen in erythema multiforme and maybe erythema migrans, but classically in erythema multiforme, and the targetoid lesions are seen in SJS-TN. Why is it important to differentiate between both? Because both can present with very severe mucositis, and sometimes you will be wondering if this is this or that. So in erythema multiforme, in addition to this mucositis means intense inflammation of the mucosa, the oral, conjunctival, genital mucosa. In erythema multiforme, you are going to see target lesions, proper target lesions that are present especially over the palms and soles. And in SGS10, what you're going to see is targetoid lesions, purpura, sheets of purpura, and eventually peeling of the skin. Okay, that is what we are seeing here. There is mucositis. Along with that, genital mucosa is intensely inflamed. It is having a lot of erosions. This is the conjunctival mucosa, and there is peeling of the skin. Here we can see the purpura, small bullae being formed, and the skin is peeled off in sheets. Okay. Now, as we are mentioning about different types of drug reactions, this is another adverse drug event. As we can see, this kind of linear, as if somebody has been brushed with this is known as flagellate dermatitis, and that is seen as a common adverse event of bleomycin. Has been asked at least twice before, important to remember this. Now looking at this, so here what we are seeing, these are periorbital. See where the skin is being peeled off, periorbital, perioral, even around the nose. So there is peeling of skin, and then it is accentuated over the flexures also, and like neck. So this is staphylococcal scalded skin syndrome, right? And the management includes administering oral antibiotics. It is associated with staph infections. The foci infection can be anywhere. It could be some lung infection, sinusitis, could be ear infections. It is commonly seen in children. Now let us look at this histopathology. So this you can easily identify with the silvery white scales. It is psoriasis. So what are we going to see in the histopathological slides? This is a question that has been asked before. If you concentrate enough, you will be able to make a diagnosis on your own. So what are we seeing? There is acanthosis. What is acanthosis? Acanthosis is increased layers of epidermis. Usually we said the spinous layer is about 3 to 10, but this is much more than 3 to 10. There is thickening of the epidermal layer. And this kind of acanthosis, where you can draw a line touching the retipex, the tip of the retipex, this is known as irregular acanthosis. In addition to that, you have these acanthosis which comes down, then goes up. They are going too much up. So there is some thinning here. This is known as suprapapillary thinning. Then what are you seeing in the stratum corneum? There are a lot of nucleus. Can you see this? Blue. So these are parakeratosis. And it is almost confluent. That is, it is present throughout it. And in the upper dermis, you are seeing a lot of dilated capillaries. So these are all classic features of psoriasis. And this is a Monroe's microabscess that is present in the stratum corneum, where there is collection of neutrophils. Okay. Now this is something which was asked in the NEET PG this time. So I thought psoriasis comes under the papilloscomus disorder and its brother, that is pityriasis rubra pilaris. In PRP, what are we going to see? There can be patches of follicular keratotic papules. Just mean that it is around the hair follicles and it is thickened and it is papular. And what we are seeing is a papilloscamous disorder. What is papilloscamous? It's just elevated plaques which have a lot of scaling. So these are papilloscamous lesions, and there are islands of sparing, areas where the skin is completely spared, and this waxy yellow keratoderma just means that the thickening of the palms and soles. So this is classical features of PRP or pityriasis rubra pilaris. Now let us look at these flat-topped, even hypopigmented to skin colored, very shiny papules. It's too small. And look at the distributions over the dorsum of the hands. Then it is accentuated over the knuckles. Sometimes it can be present over the penis. This is known as lichen nitidus. Why is it important? It has been asked before also. The histopathology is quite characteristics. If you can see that the red apex are surrounding this area of a lot of busy dermis going on here, a lot of cells here. This is ball and clutch sign. It is somebody is clutching this ball of inflammation. And what does this ball has? This ball has a lot of lymphocytes, and these lymphocytes are damaging the basal layer. So there is interface dermatitis. They are damaging the basal layer. Along with that, do you see these larger cells? So these are also containing epithelioid cells. So these are epithelioid. These pink colors are epithelioid cells. So they have all these three features. So you have the ball in clutch, then you have the basal cell damage, and then you have the epithelioid cells. This is lichen nitidus. Now let us look at another histopathology slide that comes as a MCQ. So we can see these are papular lesions, right? And these have a central umbilication, central depression. This is quite classic for molluscum contagiosum and you cannot miss it. And what we are seeing is the histopathology of molluscum. And we are seeing here is Henderson-Patterson bodies that are slowly being dispersed out. Now this is, we are seeing a photo distribution, right? So over this, but unlike SLE, there is involvement of this nasolabial fold, which is usually spared in SLE because it is a photoprotected site, right? There is erythema over the eyelids. This is a case of rosacea. And in rosacea, you have different stages. This is erythema. There is a redness. There is telangiectasia, dilated blood vessels. So this is erythemotelangiectatic rosacea. And other different stages of rosacea, erythemotelangiectatic. Second stage would be papulopustular. Then you can have phymatous, bulky changes, bulky nose, bulky chin, bulky forehead. So that can be phymatous changes, and then you have ocular rosacea. Okay. Now, what we are seeing here is pustules and papules, but more concentrated over this area, jawline. So this U-like distribution of acne, pimples is commonly seen in hormonal acne. And this is commonly seen in patients who have PCOS, polycystic ovary syndrome. And they, in addition, would have androgenic alopecia in female pattern or male pattern. They can also have acne vulgaris, especially in the U pattern. They can also have hirsutism, that is growth of hair over the chin, over the mustache area. So these are the features that can come along with PCOS. Okay. And the treatment of a hormonal acne, in addition to conventional anti-acne agents, would also include oral contraceptive pills. Now let us look at different types of alopecias. I had not discussed anything earlier in the question because I thought pictures would be more beneficial. And you need to learn these two tables because it has been asked so many times. So we have two types of alopecias. One is non-scarring alopecia. Non-scarring means that the hair follicles are intact. It's just that the hair is gone. It can regrow. It has the potential to regrow, right? In the scarring alopecia, the hair follicle is completely damaged, the hair will not be able to regrow. So non-scarring and scarring alopecia. And in non-scarring alopecia, you have infective causes. What are the infective common causes of non-scarring alopecia? So we have tinea capitis, not all the variants, the non-inflammatory variants like black dot and gray patch, ectothrix and endothrix. Then you have moth-eaten alopecia of the syphilis. Then you look at the non-infective causes. Among non-infective causes, you have alopecia areata, androgenic alopecia, anagen effluvium, telogen effluvium, and trichotillomania. It is so important that you remember this because this has been repeated many a times. So 3 A's and 2 T's: alopecia areata, androgenic alopecia, anagen effluvium, telogen effluvium, and trichotillomania. In all these conditions, once the hair goes, there is always potential for the hair to grow back spontaneously or with treatment. Now looking at the scarring alopecias, among the infective causes, we have tinea capitis, which is the Favus and Kirion variant of tinea capitis, the inflammatory variant of tinea capitis. Then we have the non-infectious causes. And what are the non-infectious causes? Very important examples. You have lichen planopilaris, lupus, that is the discoid lupus erythematosus. We had shown the pictures earlier. Then pseudopelade of Brock. At least these three you should definitely remember. Now coming to this picture, let us see what is happening here. So there is a female with increased parting of the midline hair, and the male who has recession of the frontal hairline. It is going back, and there is loss of hair in the vertex. And this type of pattern of alopecia is known as androgenic alopecia or hormonal alopecia, right? It is a form of non-scarring alopecia, and the treatment would be minoxidil and finasteride. Minoxidil is usually given as topical, even though recently oral minoxidil has been also used in practice, and minoxidil is a vasodilator. It increases the blood flow into this area and promoting hair growth. And finasteride is a 5-alpha reductase inhibitor. It is usually it is available again in topical and tablet forms, but tablet forms are being used more. Now let us look at these area of patchy hair loss, almost circular, multiple. These are also non-scarring alopecias, and trust me, if you are confused, there will be some indication in the question. It indicates that if it is a scarring alopecia or it is a non-scarring alopecia. For a non-scarring alopecia, the follicular openings will be preserved, and for a scarring alopecia, the follicular openings will not be preserved, or there will be white color scars, atrophic scars that are present. So alopecia areata is again an autoimmune disorder where the body's immunity is attacking the hair follicles, right? Now it is again a non-scarring alopecia. Let us take a 5-minute break. Sorry, there was a small technical issue. So now we are back. Again, this is a patient who has patchy alopecia, but you won't be able to identify what kind of alopecia. Again, in this question also, I was telling you, you will have some indication to suggest that it is a non-scarring alopecia to come into a diagnosis. Here also we have a patchy alopecia. The problem here is that the patient may or may not give, but the history of repeated pulling and certain dermoscopic features would be characteristic, which includes perifollicular hemorrhages, V-shaped hair that is present, V-shaped hairs, broomstick hairs, and the hair that is cut at different lengths. So on a patch of alopecia, how do you identify? There will be hair which is cut at different levels, and this is because of the chronic pulling of the hair, and this is known as trichotillomania, TTM. And what is the treatment for trichotillomania? This has also been asked. Trichotillomania is usually treated with antipsychotics and also tricyclic antidepressants. SSRIs before used previously but has found to be less effective than these two. For example, olanzapine, the second generation. Okay. Now we are coming into the spectrum of scarring alopecias. This is a localized patch of alopecia, right? And here you can see that the skin is trophied. And it will be mentioned in the question, because you cannot zoom a picture a lot, that the follicular openings are lost. So in such a patch, and can you see these white dots? These are known as follicular plugging. Then you have loss of hair, right? And you may get dermoscopic features that are mentioned in the question paper, saying peripilar cast, that is casting around, scaling around the follicle, etc. This is lichen planopilaris, LPP. Lichen planopilaris can be of 3 types. This is the classical type. Then we have the frontal fibrosing alopecia, and then we have Graham Little Picardy syndrome. But what comes in the exam? The exam previously was frontal fibrosing alopecia, where the alopecia is scarring in nature with recession of this frontal hairline. This is where the hair is being lost. But unlike male pattern androgenic alopecia, this is scarring alopecia. Along with that, there is loss of eyebrows and sometimes even eyelashes, and it is seen in women, especially older women. Now this is DLE. We had mentioned earlier that there is peripheral hyperpigmentation followed by central depigmentation. And if you look close, and if there is some dermoscopic pictures, you might be able to see follicular plugging here also. Now this is the inflammatory variant of tinea capitis. We can see these yellow disc-shaped space where the hair comes out. These are scutula, which is seen in favus type of tinea capitis. And this is a boggy swelling. Looks very inflammatory, red, tender, pus-filled, right? It can even have superficial pustules. This is known as chirion. So there is a table that we have differentiating different types of tinea capitis. As we had mentioned earlier, black dot and gray patch are non-scarring. And then we have chirion and favus, which are scarring. Right? If you ask what is the drug of choice in tinea capitis, the answer is always griseofulvin. And what causes chirion type of tinea capitis? It is usually the zoophilic tinea, like Microsporum canis. That is why there is this intense inflammation reaction against, because it is not, these fungi is not accustomed to human skin, and it is tinea capitis in general is most commonly seen in children. Okay. Now we have this favus type, where it is caused by Trichophyton scholleni. Now coming to the leprosy, this has been asked before, how to identify which spectrum of leprosy is this image falling into. So there will be some indication in the history also. What are those indications? So when we look at the number of lesions, if you are going from LL to TT, this is the lepromatous spectrum. Then you have BL, BB, BT. So basically we are trying to see where this spectrum will fall in. So number of lesions will increase as you go from tuberculoid to lepromatous pole. Now the size of the lesions will decrease as you go from tuberculoid. So the tuberculoid spectrum will have large lesions, while the lepromatous spectrum will have smaller or even diffuse lesions. Then we look at the borders. So this will have a well-defined border in the tuberculoid, especially in the TT. In BT, you see that slowly, the definition of the border is being lost, forming the satellite lesion. In BB, you will find out the typical Swiss cheese appearance with well-defined borders inside with a little bit diffusing outside like this. Then in BL, you will see that the center of the lesion is very well defined, but peripherally it becomes ill-defined. And in the LL, as we can see, it will be very small or it will be diffuse infiltration. And the nerves, as we go from TT to LL, the number of nerves will increase. That is, number of nerves will increase. Here it could be very few. In LL, it will be almost symmetrical glove and stocking type of sensory loss. The one thing I forgot to mention is that the sensory loss, we have to remember that even though the sensory loss is more diffuse because of the neural involvement in LL type of Hansen, in the particular skin lesion, the sensory loss is more profound in TT spectrum. That is almost 100% of the skin lesions will have no sensations. 100% sensation will be lost in the skin lesions. But as we go into the LL spectrum, the skin sensations may be even normal, but as I had mentioned earlier, the glove and stocking pattern, because of the neuropathy, the sensations in the extremities will be much more widespread than the tuberculoid spectrum. So here we can see that there is diffuse infiltration. Diffuse infiltration. And if there is diffuse infiltration, without a doubt, it is in the lepromatous pole, that is lepromatous leprosy. Here what we can see is this annular appearance or Swiss cheese or punched out appearance. And this is seen in BB Hansen. And BB Hansen is almost always in reaction. That is why these lesions will be red, turgid at most of the times. Now let us look at this. This is a large hypopigmented macule. Again, larger lesion, but with a satellite lesion. So once it becomes large, it becomes satellite. This will come in the BT Hansen spectrum. Now let us look at this. This is so sharply demarcated, has a turgid look to it, and this is in the TT Hansen's. Okay. Now the one we had discussed in detail in the first session, this is indeterminate Hansen. Telling you again, without clinical details, you can have a multiple differentials for this single hypopigmented macule. Scaling is there or not? Is it normoanesthetic? Is there any atrophy? So many things that you will need to ask further, but this is something how indeterminate Hansen's will look like, and that is why it is important to differentiate it between pityriasis alba and pityriasis versicolor, etc. Now this is cutaneous larva migrans, which is caused by the ankylostoma species. Sometimes it can be caused by strongyloids also, and the treatment is albendazole. Now this has been asked at least 2-3 times as far as I remember. What are we seeing here? So what are we seeing here is a rolled out border which is elevated, which has a pearly appearance. If you even see here closely, that pearly appearance is here also. Even here, rolled out pearly borders, well defined elevated borders with central ulcers over face. These are all over involving the face. So you have pearly and raised rolled out edges, and the history will give you that it's an elderly or middle-aged person and with history of sun exposure, like a farmer who goes out a lot in sun or who is a Caucasian. In white people, the risk of skin cancer is much more. So this is a BCC. Please don't forget it. Look at these signs. Instead of marking something else, you should always look at the morphology. These rolled out ulcers, rolled out borders with ulcers in the center. Okay. I think we are almost done for today. Thank you so much for listening to me. Please keep this last PDF with you, and in between your revision sections every day, or maybe once or twice in a week, you just go through the pictures. You don't have to memorize it a lot, because the visual memory is much more effective than what you read or try to memorize. What you see, you always remember. So keep on revising these pictures once in a while, at least twice or thrice in a week. You have to revise this so that you don't miss on these most important topics in dermatology, which is obviously high yield, so many repeated topics, and you will be able to score much more. Okay, and I hope you will have a good time. Thank you so much.